for that introduction. Like she said, my name is Ashley Casper, and I will be with Dr. Mentis. And we're here to talk to you all about upper respiratory infections in the pediatric setting. We're going to kind of tag team this, so hopefully this all works out okay on these screens.
At the end of today's short lecture, you should be able to recognize signs and symptoms of upper respiratory infections in pediatric patients, consider differential diagnoses for these children with URI symptoms, and we'll also review non-pharmacologic and pharmacologic measures that we can offer to families for URI management from an evidence-based perspective. A little poll to start out. You can just think of the answer or talk to a friend if someone's nearby. But how many children less than 12 years old were diagnosed with an acute upper respiratory infection at Norton outpatient facilities since January 2024? And this would have been taken, this data from earlier this month. So give it your best bet and see. And the answer is, so we had some good variety of answers here. We actually had over 25,000 viral upper respiratory infections diagnosed so far this calendar year. Out of all the patients that our outpatient facilities saw, almost 400,000. This diagnosis or similar diagnostic codes were used for about 25,000 of them. And we're just getting started. The season is rolling in hot, so a lot more coming our way, I'm sure. URI signs and symptoms are probably pretty familiar to you, but they can be pretty broad as well. And so we'll see kids present with headaches, conjunctival injection, and eye discharge, often bilateral, runny nose and congestion, low appetite, often because of the congestion, having a cough, ear and sinus pressure, fevers, lymphadenopathy, especially cervical, as well as sore throat and hoarseness or kind of hoarse voice. So fact or fiction, the color of the nasal discharge is a clue towards a viral versus bacterial etiology of the infection. This is actually fiction. And so one of those old wives' tales that we're always told from families is, well, it used to be clear and now it's green. Really, that's the natural course of viral illnesses. And so the color of the discharge doesn't tell us a whole lot. Especially, but we can kind of keep it in mind in the entire setting, especially if we're wondering about other diagnoses or other differential diagnoses. But really, we expect the color to change. That's just kind of part of the game. And so certainly we know the symptoms of what a regular old run-of-the-mill viral upper respiratory infection looks like, but there are some things that might point us in a different direction that we should have on our differential. In a patient with unilateral nasal discharge, especially if they don't have a lot of other symptoms going on, we might be thinking about a nasal foreign body. Oftentimes these will be unilateral, purulent, and often foul smelling. And so thinking of younger kids or developmentally delayed kids that have put beads or peanuts or really anything else that you can imagine up their nose. Pretty low risk to do like the mother's kiss technique, which can help to expel these things. And I encourage you to look up a YouTube video about it. There's lots of good educational content on how to perform that. A pretty low risk intervention if you think that someone might have stuck something up their nose. In a child with a history of allergies and no obvious encounter with a sick person or no fever, and let's face it, who in our area doesn't have some allergic symptoms? We definitely could be thinking of treating seasonal allergies as part of their constellation of symptoms. Pretty low risk as well to start a second generation antihistamine like cetirizine or loratadine if they're coming in with kind of this allergic picture without obvious sick symptoms. I wouldn't necessarily expect an impact in symptoms if they have a virus and you're giving them allergy medicine, but I think it's something that you can offer families if they might have an allergic piece going on. In patients with fever and sore throat without other viral symptoms, this is definitely when we want to start thinking about strep throat. This is something that I feel pretty passionately about. And it's that when we have patients that are coming in with viral symptoms, cough, runny nose, hoarseness, those are kids that we do not want to test for strep throat. We know that in a time when there's lots of strep infections going around, up to 20% of kids can actually be carriers of the disease. And the reason that we treat strep and test for it and treat is because we don't want to prevent acute rheumatic fever as a complication of strep. However, carriers are not at high risk of acute rheumatic fever. The strep test is really good at telling us if they have strep bacteria present in their oropharynx, but it's not really good at telling us whether that's what's causing their symptoms. And so we want to avoid unnecessary testing and treatment of strep if it's not actually contributing to their symptoms. So a lot of times I know it's part of protocols to have the strep swab done in triage at urgent care or even in our primary care clinics. But really, if you have a low pretest probability of strep, I discourage you from testing. The side effects of this might be unnecessary antibiotic use, possible listing of allergies to these antibiotics that are erroneous. And even we've seen kids get tonsillectomies and have complications of that as a side effect of kind of over testing. So be judicious in that effect. One of our wise infectious disease doctors has said, if you would want to get an RPP to name the virus, you shouldn't want to get a strep test at the same time. We also want to avoid testing for strep in kids less than 3 years of age because they don't have that risk of acute rheumatic fever as well. And so not a high utility in testing there. Of course, viral upper respiratory infections can always lead to complications. One is a superimposed bacterial infection. And so if they come back in with fever, especially above 102.2, and especially later in that illness course, we want to think about acute otitis media and pneumonia. And so first thing I'm looking at is their ears well, not the first thing, but I definitely want to look in their ears. And I'm looking for bulging of the TM, not just redness or fluid behind the eardrum, but I want to see that it's coming out at me like a donut or like a cervix. And if they have a high fever and ear pain, that's a clue that they would be diagnosed with acute otitis media. Remember, not every ear infection needs treatment, and 80% of them get better on their own. So the AAP has great guidelines on watchful waiting that I encourage you to become familiar with and utilize. But it's very common to see, especially in younger kids, an ear infection as a side effect or kind of as a secondary infection from that viral upper respiratory infection. If they're coming in with the fever later in that illness course, I also want to give their lungs a good listen, because if they have cough, fever, and focal findings on lung auscultation, that's diagnostic for pneumonia. And you don't need to get a chest x-ray or like radiate them to confirm that. You can do that diagnosis clinically. Wheezing or kind of an asthma exacerbation as a complication of URI is also fairly common. A viral trigger is a really common trigger for asthma exacerbations. One thing I've noticed since living here in Kentucky is that what we consider wheezing as medical professionals and what the community calls wheezing are two different things. And so when a family tells you that their patient's wheezing, what I've found is that they often might mean the kid's congested and is breathing noisily. And so make sure you tease that out and clarify with families whether they are just congested or if it's actually coming from their bronchospasm in their lungs. But certainly, viral illnesses can trigger asthma exacerbations. Remember too that a nebulizer is equivalent in strength to a puffer with spacer. And so if you don't have spacers in your ICC or in your clinic, I encourage you to talk with your managers about having those available. It's a really great way of kind of simplifying the patient's care if you're able to give them an inhaler instead of a neb. If a patient has a prolonged cough for greater than 10 days, that's when we might be thinking about Moraxella. We're seeing a lot of walking pneumonia these days. Might be thinking about pertussis or just an alternative diagnosis that isn't kind of related to this acute infection. Diagnosis of a URI is clinical. You have all the skills you need. And really, viral PCR testing has pretty low utility. Knowing the specific name of the virus that's causing your runny nose and cough isn't really going to change your management. And it can be very, very expensive for the healthcare system. I think an RPP costs like $1,000 or more. And so be judicious with that. Every test has a place. For the vast majority of kids coming in with viral URIs, they don't need testing. However, it can be useful in specific settings. So in public health settings, testing for COVID is very important. And in specific patient populations, like a febrile neonate or a kid that's had a fever for 5 days or longer, it might sway your clinical decision-making and management to know whether they have some virus that's causing their symptoms. As with many other medical problems that we treat, there are multiple options for treatment. We have non-pharmacologic measures and a few pharmacologic measures that we can use to help kids whenever they're dealing with these symptoms. Every kid that walks in the door with a viral URI should leave with a plan for supportive care. And I express to families that it is frustrating and it is hard that we don't have great medication options to help kids. But I say it's the frustrating but effective supportive care game. And so kids should definitely have increased fluids. We want to make sure they're not getting dehydrated, and being more hydrated can loosen up their secretions and help them feel more comfortable. Of course, getting lots of rest and using a cool mist humidifier can help to loosen their secretions as well. With the caveat that I encourage families that if they're going to use a humidifier to make sure that they're using distilled water and that they're cleaning their humidifier every single night, because we don't need mold being thrown into the air either. Nasal saline spray for younger kids or drops for infants can be really helpful to loosen secretions. Babies are obligate nose breathers, and so I always recommend suctioning the nose before feeds or before bedtime or they go to sleep to help them breathe more easily. And this can also help with cough, because most of the time the cough is coming from drainage of that congestion dripping in the back of the throat. And so the more we can get out, the more comfortable the kids will be and the fewer symptoms they'll have. Finally, head positioning or sleeping kind of with the head elevated can be helpful to drain things down, though we don't want kids that are under 1 to be sleeping elevated. We want them flat on their back every single time for safe sleep purposes. Finally, we have a variety of pharmacologic options. We can use symptomatic treatment, complementary alternative medicine. There maybe, but probably isn't the place for antibiotics and preventative measures. And so I'll pass it over to Ashley to dig into that a little bit more.
Thanks. So we're going to start with another question, fact or fiction. The FDA and AAP endorse the use of cough and cold preparations in children less than 12 years of age. And that is fiction. So actually the FDA and the American Academy of Pediatrics recommend to avoid cough and cold medications in children less than 6 years of age and to avoid decongestants in children less than 12 years of age. So we're going to kind of go through all that stuff here in the next portion of this presentation. With cough and cold preparations, so there are more than 800 cough and cold preparations in the United States. We've kind of broken this down to discuss the following major categories in cough and cold medicines, and each of the categories will be outlined in the slides to follow. So the major categories we're going to talk about are antihistamines, decongestants, antitussives, expectorants, analgesics, and antipyretics, and then combination products. First category we're going to talk about are antihistamines. So with antihistamines, the mechanism of action is to block H1 receptors on the nasal vasculature and compete with histamine for receptor sites. Its effects are believed to be caused by the anticholinergic drying action on the mucous membranes. In literature review, there is no evidence they have any benefit in small children other than the fact that they might induce sleepiness, which sometimes a parent might be looking for that during these viruses. In terms of adverse effects, you can see sedation. You unfortunately can see paradoxal excitability. You can have dizziness, respiratory depression, hallucinations, tachycardia, heart block, arrhythmias, dry mouth, blurred vision, or urinary retention. So there are things to consider whenever we're talking about antihistamines in this population. The next cough and cold preparation to discuss are decongestants. So how do decongestants work? They are going to decrease our nasal congestion via vasoconstriction in the nasal mucosa. There are 2 different types of formulations when we think about decongestants. So we can think about our topical versus our systemic formulations. And when we think about topical decongestants in children, There can be difficulties in administration to allow the medication to actually reach the intended target site. And then we also need to consider rebound congestion. Rebound congestion can be dangerous in pediatric patients less than 6 months of age who are extremely dependent on that nasal airflow for respiration. When you look at literature in infants less than 1 year who were diagnosed with RSV, they treated them with 0.125% phenylephrine drops compared to normal saline drops, and there was no change in their clinical respiratory scores compared to the normal saline drops when they used the actual medicated decongestant product. Another thing to think about are adverse effects for our systemic decongestants. So we can see things like tachycardia, irritability, agitation, sleeplessness, hypertension, headache, nausea, vomiting, palpitations, seizures, dystonic reactions. And then when we think about the topicals, so we can have drying of the nasal membranes, we can have nosebleeds, and then like we discussed on the previous slide, rebound congestion. So that's the reason why when we think about using a product like Afrin, we do not recommend that it's used for more than 72 hours to try to mitigate the potential for rebound nasal congestion. The next thing I kind of just wanted to pop up here was to look at the actual prescribing habits for the decongestant pseudoephedrine. So this is data that was pulled from Epic from the beginning of January to about the first week of October. So in total, there were about 426,000 prescriptions that were generated in the outpatient realm for this population. And whenever we look at the prescribing for pseudoephedrine, about 7,800 of those were prescriptions that contained Sudafed. So like we talked about from the earlier slides, decongestants are not recommended for that particular age group. And then when we break that out and look at the patients that are even slightly younger, this less than 6 years of age population, we saw about 3,000 prescriptions containing pseudoephedrine in that age group. I'm going to go back to our cough and cold prep. So for antitussives, the mechanism of action for that is to inhibit cough through a central or peripheral mechanism or a mixture of the two. I think definitely for parents, cough can be the most frustrating and concerning symptom. It usually keeps the child up at night. It can keep other family members and siblings up at night as well. So it's really important for us to talk to parents that our cough is really actually a beneficial protective airway reflex. And coughing helps clear these excessive secretions and can help maintain airway patency. When we look at studies in children, studies do not show any benefit in cough suppression compared to placebo for either the narcotic containing or non-narcotic containing cough medicines. And then another thing to think about with our pediatric patients is what about patients with asthma? So in that patient population, if we were giving them these antitussives, it's actually going to make it harder for them to expel mucus. So that would be something to keep in the back of our mind too. When you look at adverse effects, so there's a variety of adverse effects similar to the other medications that we've already talked about, but things like drowsiness, nausea, dizziness, respiratory depression, sedation, hypertension, tachycardia. But one of the meds we specifically wanted to highlight here are Tessalon pearls. So with the antitussive Tessalon, there is a risk for seizures, cardiac dysrhythmias, and death. It has a very narrow therapeutic index. And if you were to have an overdose or an accidental ingestion, it has resulted in deaths. For pediatric patients, the onset of symptoms can actually be less than 5 minutes with only the administration of 1 to 2 capsules. It is not approved for our patients who are less than 10 years of age as well. Moving on to expectorants. So they are thought to act as an expectorant by increasing the effective hydration of the respiratory tract. It maintains the cell layer needed for ciliary clearance and reduces viscosity of respiratory mucus. And then by doing that, it's going to further facilitate the removal by a natural clearance process. So when we look at studies, in terms of studies, there have not been any changes seen in sputum quality, volume, or in cough frequency reduction in adult patients. And then in pediatric patients, there has not been any benefit shown in review of literature. And then when you look at adverse effects, so things to consider: dizziness, drowsiness, headache, nausea, vomiting, and stomach pain. Analgesics and antipyretics. So there's definitely a place in therapy, but there's just the caution in use, because if we were to have a parent who was giving their child a combination product, which we'll talk about in a second, a lot of these combination products also contain acetaminophen, so it can lead to duplicate administration. And then when we think about our analgesics and antipyretics, we're using these because we want to, kind of control like aches, pains, discomfort, irritability from a fever. But when you look at that, Tylenol and ibuprofen in adults was actually shown to show trends in longer duration of viral shedding. There aren't many studies about that in pediatric patients, but I just kind of wanted to highlight that here. And then the adverse effects for these products are just going to be dependent on which product was selected. The last thing we wanted to talk about here are the combination products. Like I said, there's 800 cough and cold preparations in the United States. So there is a generous and wide variety of options when we are looking at these combination products. So most combination products are going to have an antihistamine and decongestion, or they're going to have an expectorant and a cough suppressant. And we think about that a little bit more, it seems like quite an odd combination to put together an expectorant and cough suppressant, because really what's going to happen with that combination is you're going to have thin secretions, but then you can't expel them because we have cough suppression. So the products are really working against each other for those combination products. When you review literature, there was really no difference in symptom relief in small children. And then for older children and adults, there was a small decrease seen in the nasal symptoms for some of these combination products. So this slide here is just showing a little information about a combination product called Pharm.D. From January 2024 to about October 2024, there were 846,000 prescriptions that were prescribed in patients less than 18 years of age. And of those, 12,000 were actually prescriptions that were containing brompheniramine for those patients that were less than 18 years of age. And then when we look at our slightly younger population, those less than 12, we had about 400,000 prescriptions that were generated, and nearly 8,000 of those were containing brompheniramine. And then that last little sliver of an age group is less than 6 years of age. We had nearly 3,000 prescriptions for brompheniramine in that patient population. And then I'm going to give back over to Allie.
This is a chart showing some data published by the National Poison Data System. As you guys know, I'm sure we're constantly seeing kids in the hospital admitted for different exposures. And so they've recorded through the Poison Centers of America, they've recorded every call that they got to for an exposure. And they found that last year, or in the year 2022 rather, in kids 5 and under, cold and cough preparations were in the top 25 number of exposures that they got called about. And so on this chart, we'll see that it made up about 2% of all of the calls that they obtained. And so having these things around, even if they are not being used to treat cough and cold, can still be hazardous. And so if you give somebody Tessalon pearls, for instance, know that there might be kids at home that could get into them and could have a seizure or death after just ingesting 1 or 2 of these tablets. And so, like I said, this includes anytime the poison center was called. And so it could include accidental ingestions or dosing errors if families calculated the dose wrong and then called the poison control for help. And so keep in mind that if you're prescribing something or you're recommending something, it'll be in the family's house. They're not just going to ditch it after the kid feels better. And then this chart shows us the number of fatalities with exposures. And so we found that cough and cold preparations were involved in 10% of the exposures reported to the Poison Control Center that resulted in fatalities in kids 5 and under. Important to note too that 40% of the poison control cases that were reported were in kids that were 5 and under. And so really this is a huge indicator that the cold and cough preparation availability in the home is a problem. And so be mindful of your prescribing practices and consider and reflect on how you might be or might not be contributing to this risk. Of course, we always want to meet families where they are, and a lot of times they're coming to us asking questions about complementary and alternative practices or old wives' tales or things their parents did. My basic strategy when tackling complementary and alternative medicine is to say, 1, does it work? And 2, is it safe? And so for some things, it's a solid sure. For others, I'd really, really recommend against it. And so let's dig into some of those pieces. Honey is a very powerful cough suppressant. There's been lots of studies that have compared it to placebo, compared it to Benadryl, compared it to dextromethorphan and other cough suppressants. And they found that honey improves the cough frequency and the severity of the cough that kids experience. And so I will frequently, pretty much every single time, recommend honey on a spoon or in some tea to families. A lot of times they'll say, oh, well, I have this name brand honey containing product. Sure, but most people have honey sitting around in their house. There have been studies with specific doses of this, like 1.5 milliliters of this, or for different age groups. My recommendation is put it on a spoon and go to town. However, we definitely don't want to use honey or any honey containing products in kids less than 12 months of age due to the risk of botulism. And so I always make that clear to families whenever I'm advising them on this. Chicken soup is something we've heard of as helpful for the common cold. It provides hydration and nutrition to families or to kids so they don't get dehydrated. And the steam can help with congestion kind of by opening up and moistening their airways. So for me, chicken soup is a solid thumbs up. And if they ask me about it, go to town, go crazy. Next, we'll often hear about families using vapor rub. This can give a cooling sensation to the chest. The menthol in it can kind of give the illusion that you're breathing more easily. However, it doesn't actually do any decongesting. It just kind of makes you feel more comfortable, which is fair. However, we got to pay close attention to the ingredients in it. Vapor rub for adults contains camphor, which is an herbal ingredient. And if ingested or kind of rubbed on the mucous membranes, this can cause seizures and can be poisonous. And so additionally can of course cause skin irritation on sensitive skin. There is a baby version of vapor rub products, which are non-medicated, and they include eucalyptus and lavender and rosemary. And so they probably won't do much for you, but they're at least safer options. However, recommending vapor rub especially for younger kids that are at risk of putting it in their mouth or rubbing it on their eyes or nose, for me, it's a no. And so I have no problem with recommending against that for families. It can be unsafe and it's not helpful. And so for me, it's a pass. Finally, we'll often be asked about different supplements and like minerals that we can use. Unfortunately, there's not a whole lot of evidence in kids to support the safety and efficacy of these things. And so there have been some Cochrane studies for echinacea, for instance, for the common cold, and said that some of it might maybe be better than placebo. However, there isn't evidence in kids for this. For vitamin C, for instance, a lot of people say, oh, well, I felt a cold coming on, so I've just been loading up with vitamin C products. you're just going to pee out whatever your body doesn't absorb, and it doesn't really reduce the severity or duration of your symptoms. But if you want to eat oranges, I'm a pediatrician, so I'm here for it. Finally, zinc and selenium. There's really not any evidence that it's helpful, and zinc tastes really, really bad. And so for me, these are things that are like, I don't have really any evidence that they work. I don't have clear evidence that it's harmful, but really we just don't have any studies in kids that can inform our practices. So for me, if a family says they're already doing things, I'll inform them that, I can't tell you whether it's safe or not, but I can tell you, it's probably not going to help you. And we have other things that we can be doing instead. All right, back to you, Ashley.
The next thing we kind of just wanted to touch on here are antibiotics. So I feel like that's something where I think there's a lot of pressure when patients present to feel like they need to leave with something in their hand, especially, if they have a fever and they seem to have symptoms where, we think that there's an infection. But when we're thinking about viruses, that's really not going to be helpful in that situation. So antibiotics are frequently overprescribed and they're rarely warranted for our upper respiratory infections. This overprescribing can be harmful because it can lead to antibiotic resistance. It increases the cost of healthcare. It can lead to increased incidence of adverse effects as well from the medications that are prescribed. We have our Norton Children's Hospital has access to the Sharps database. So for those of you who don't know, Sharps is an initiative. It's called Sharing Antimicrobial Reports for Pediatric Stewardship. So basically there's a multitude of pediatric hospitals across the nation that upload their data quarterly, and then Sharps helps you compare your site to other sites in the nation. And so on this graphic, this is looking at trends in antibiotic use among acute upper respiratory infections. And we at Norton Children's are the orange line. And then the sites that it's comparing to, our peer sites, are that blue line. So the trends in the proportion of ARI patients who received antibiotics is shown in this figure. For this, I'm trying to explain this most succinctly. So what we have here, the numerator is the number of antibiotic treated ARI encounters, where the denominator is the total number of encounters with the ARI diagnosis. So we have those two separate trend lines shown within each patient category location. So it's broken down to ED, urgent care, and then primary care, where a patient might be seen. And then what they do for Sharps is they look at Norton Children's, and then that other line, obviously, I talked about are those peer sites, but our site data is not actually included in that peers trend. So it's a way to kind of like differentiate that out. And then it's a little bit hard to see, but this data is for the most recent. So that very far right orange dot on there is Q2 data. So if you look at Q2 data, our use compared to other sites is slightly higher. When you look at us at urgent care specifically, even ED, we're a little bit higher, and same thing for primary care. The next one that I wanted to look at was our trend line of amoxicillin use. So we, again, are the orange line here. And if you look at our ED, we've definitely made some improvements there, and we are right on trend with all of our peers in our prescribing habits for amoxicillin use. In our urgent care facilities and our primary care facilities, we have done a good job at those places as well, and being lower than our peer sites. So that is great work in those places. And the last thing I wanted to look at is this trend line in azithromycin usage. So even when we kind of take into account these mycoplasma outbreaks and these very frequent diagnoses for walking pneumonia, our use at Norton Children's Hospital in the ED, urgent care, and primary care facilities is much higher than our peers. So definitely think that's something that we're trying to look into and hoping to see growth where we can come down in our prescribing for that as well. The next thing to really talk about here on these next two slides is we have tables for conditions where we would consider treatment with, antibiotics or antivirals if necessary. So it's going to be things like acute otitis media, acute rhinosinusitis, COVID, flu, group A strep pharyngitis, if it was those patient populations that Allie talked about earlier, and then community acquired pneumonia. So like she talked about for acute otitis media, there's, these signs and symptoms for a clinical diagnosis. And then there are recommendations out there for which patient population or age groups can we do this watchful waiting period. Like she talked about, there are patients who will improve without antibiotics. So if, a family is willing to do that, we can always try to go that route. But then if we do have patients where we need to actually give them a prescription. Obviously, amoxicillin high dose is our first line treatment for patients who have severe illness or the younger patient population with bilateral infections. Otherwise, you can consider that watchful waiting. And then we think about rhinosinusitis. So I have the symptoms up there for you. And then if we can do watchful waiting in this period as well, that's always something to consider. And then if a prescription is required, those are going to be the patients who receive amoxicillin or Augmentin. And then for COVID-19, the signs and symptoms for that: fever, chills, cough, shortness of breath. And we do consider remdesivir for our high-risk patient population. There's lots of information out there about who those high-risk patients are. So our immunocompromised patient population, perhaps sickle cell patients. There's a lot of stuff out there for that. And we have an order set that is actually built for patients that can come in an outpatient setting and receive remdesivir who don't need to be admitted to the hospital. Another thing to look at is the flu. So I think that the AAP and the CDC have really nice guidance on who should we be prescribing Tamiflu treatment to. So if we have patients that come in, they test positive for flu, you can consider treatment if you have had symptoms for less than 48 hours. And then that will be extended in patient populations that are more of our higher risk patient population. One of the things to think about with Tamiflu, sometimes the side effects from the actual drug might be worse than how you actually feel when you have the flu. So there's always the risk that you might prescribe Tamiflu and then the family ends up stopping it early because unfortunately it might not taste that great and the patient might not feel that well either. So we always risk resistance for those people too who don't complete their courses. Moving into group A strep pharyngitis. So we kind of talked earlier about who we're going to try to screen or not screen. And then for those patients that do end up needing treatment, the recommendation is amoxicillin. There's lots of information out there about different dosing schemes. Amoxicillin for pharyngitis is great and wonderful, and you can just give it once daily for ease of administration for families to try to help with compliance. And those doses max at 1,000 milligrams. So you might have patients that are receiving what appears to be an adult dose, and that's because even adults max at 1,000 milligrams for our strep pharyngitis treatment. And then the last thing to talk about here, Allie did a wonderful job talking about diagnosis for community acquired pneumonia. So again, for those patients with that diagnosis, amoxicillin high dose is going to be our first line treatment. When we have people who are under immunized, you might want to think about that and maybe covering for other types of organisms that might be missing. So those might be people that end up on Augmentin. The last thing that we wanted to touch on here for this was just really prevention. So there's, I think, a lot of vaccine hesitancy in this day and age, but if we can have these tough conversations with people about vaccines, we have lots of vaccines on the market that can hopefully prevent some of these viruses. So the flu vaccine, pneumococcal vaccine, COVID vaccine, and RSV vaccine. So there are new recommendations for RSV vaccine in our our youngest patient population, and then for our elderly, and that might hopefully help with this in between age group as well. Hopefully we'll see a reduction in RSV. Another really key component for that is hand washing. So I think that when we have patients who, go to daycare or they go to school, really teaching them good hand hygiene habits can go a long way. So hand washing is a super helpful preventative measure as well that I think sometimes we just forget about because it seems easy. Switch back over.
All right, as we're wrapping up today, I wanted to drive home a couple of key points for you. So remember, when a patient comes in with a viral upper respiratory infection, be considering whether, other diagnoses that could be mimicking this or that could be complicating this picture. And whenever possible, utilize those non-pharmacologic measures. I think it's like Ashley said, families come to us wanting help. And it's frustrating, I think, for everybody to say, we don't have great medicines that we can give you, but we're not without hope. Here are things that we have strong evidence that's helpful. And so encouraging families, wow, you're doing a great job. Let's stay on top of that suctioning. Let's, give them some honey for cough because we have strong evidence that it's safe and that it works. We know that cough and cold preparations are not recommended by the FDA or the AAP because they can have serious and life-threatening side effects. And so when families are asking for these medications, feel confident saying, if I had a cough and cold medicine that I thought would help you and that was safe, I would give it to you, no doubt. I'm not trying to withhold things that'll make your child feel better. I just know that these things are not safe and I cannot recommend them for you. We know that overprescribing antibiotics will lead to antibiotic resistance, increased cost, and increased adverse effects. So be judicious with your testing for bacterial illness like strep and in your treatment of actual bacterial diseases. And of course, avoid using antibiotics in viral upper respiratory infections unless it's truly indicated by an otitis or pneumonia that needs treated. Finally, vaccinations can help with prevention. And so be very positive about them. And if you offer vaccines in your clinic or urgent care, wherever you're practicing, presume a positive answer. So instead of saying, do you want your flu vaccine today? Hey, you're here. Let's grab your flu vaccine while you're here, and then it'll be taken care of for the season because we strongly recommend it. And we recommend getting it by Halloween. So if you haven't had yours yet, make sure you're checking that box too. Any questions or comments? I think there were a couple of things in the chat that we can dig on back to, but we have some time here to go through some things.
Yeah, I was going to say, I think there's one in the chat and then one in the Q&A. So I don't know which one you guys want to take first, but in the chat, someone asked about one of the charts. I'm presuming probably the antibiotic use one. Was that just representing URI or also when there was a diagnosis of secondary otitis media?
So this was back in the antibiotics.
Yeah, I believe, yeah. And when you were showing like our usage compared to other organizations, they were curious if that was just URI or also if they had a secondary diagnosis of otitis media, would that impact that antibiotic use, I guess, metric?
So, so you mean the Sharps data, or do you think it was from this chart? I was trying to decide, did someone mean this chart right here?
This was posted back on the Sharps data.
The Sharps data. So I don't know if with Sharps, I'm trying to think if in the screening where I'm dropping all this information in, if it has anything that differentiates, is it ARI or was there also a diagnosis code of otitis media? And I cannot remember if it does that or not. So I will look into that and see if I can find out.
I'm suspecting it probably would include some antibiotic use for AOM. But we also know that watchful waiting is probably underutilized. And so maybe this is a sign that we can be doing more watchful waiting if that is the case.
And then I see a question too in the question and answer section that talked about side effects with Tamiflu. And then there was a mention of another agent that is a newer, I guess, on the antiviral agent. So to be honest, I don't know in terms of like coverage. Do you mean like drug company like cost or coverage? If that's increasing, I definitely know that's not going to be on anybody's preferred list. So I don't know if that answers the question or not. But side effects for that one in terms of like compared to like Tamiflu, you still are going to have diarrhea is about 5%. And then with vomiting in pediatric patients, that was about 5% as well. So most of those side effects are going to be on trend with what you see with Tamiflu. I haven't seen anything out there that talks about one or the other being more well tolerated. And I think the CDC's recommendation is still going to be just for Tamiflu, probably because it's more available.
She did add in the chat that she was asking about insurance coverage. So if that helps.
And Ashley, am I right in saying with Tamiflu, it gives you on average about like an 18-hour decrease in symptom duration? So not a huge
Yeah, most of the time it'll say it shortens your duration of symptoms by less than 24 hours. And so when people sometimes consider the side effects, a lot of times they're not going to want to do it if it's in an outpatient setting. Now, I definitely think for people who are admitted to a facility and have other complications from flu, those patients, that is a definitely more reasonable option to treat it if it can be treated. And then there's another question in here. I don't know if you know the answer
warm
to
air
this, Allie,
humidifiers.
just about increased infections with warm air humidifiers. I do
I
not.
haven't necessarily seen any data about an increase in infections, but of course, I think there would be an increased risk of like mold development in the humidifier itself. And then there's always a safety risk to consider that a child could burn themselves on the water as it's coming out or on the machine itself. And so I'd be curious about whether there would be, if that's an option compared to a cool mist humidifier. A cool mist humidifier probably has an improved safety profile over warm.
Did anyone have any other questions for us?
I just want to say thank you to you both. I mean, I worked in adult world, but this was even super helpful for me to hear this information. It's wonderful. So, again, thank you guys so much for putting the time into this.